Your life now.
Good evening, everyone. We are here for our first CME of the Varanasi Ophthalmic Society of this year, and we are lucky to have Professor Rajesh Sinha sir with us and as a guest speaker. Before I would like to proceed further, I request the President of Varanasi Ophthalmic Society, Dr. Sanjay Thakur sir, for his welcome address. Sanjay sir, please.
Thank you, Deepak. I'm really glad that we are starting our first meeting with a stalwart in Ophthalmic Society of India, Professor Rajesh Sinha. I welcome you, sir, and I will give a brief information about Professor Sinha. He is a professor of cataract, cornea, and refractive surgery in RP Center of Ophthalmology, and he has got many, more than 300 papers, international publications. He has written several books. He has authored many, and he has contributed many chapters in many books. So he is a person who is probably the most right person to start our and I really and I thank you, sir, for giving your valuable time from your very busy schedule. Thank you, sir, for joining us and giving your opinion about a very serious problem that is increasing day by day. Keratoconus.
Thank you, sir.
Thank you, sir. The chairperson of today talk, Dr. Ojha sir, also joined us. Dr.
Good evening.
Ojha, sir.
Good evening.
Thank you,
Yes.
sir.
Good evening.
Good evening, sir.
Now I will request our scientific secretary, Dr. Diksha, to moderate the session. Dr. Diksha, please.
Good evening, our respected seniors and my friends. So why did we choose this topic today, keratoconus? Because as now the patients are more aware regarding their refractive errors and their diseases. So we should know when to refer the patients, how to deal with the keratoconus patients. We should know when to refer to the cornea specialist, the management using contact lenses or surgical intervention when it is needed. So that's why we chose this topic, and we have none other than Professor Rajesh Sinha sir to share his knowledge and his experience on this management of keratoconus. So I would like to invite sir to share his talk. Sir, please.
Thank you, Dr. Diksha. Big thanks to Dr. Deepak, Sanjay Thakur sir, and Dr. Vivek, and everyone in Varanasi Ophthalmic Society. It's a great honor for me to be here in the CME of VOS for this calendar year. And as Dr. Diksha has very rightly mentioned that the disease of keratoconus is being detected more now because of the advancements in the technology, and that is why we get to know more and more cases of keratoconus, and that's why it's very essential to have a wonderful understanding as far as its management is concerned. And as far as management is concerned, it has evolved over the years with time. This has been known for last many years, but the advancements are always there in the management of keratoconus. So when you talk about the management or its advancement, so we have to understand the disease per se, first of all, and then of course how things have evolved in terms of managing the disease. So keratoconus is a progressive non-inflammatory bilateral ectatic corneal disease, results in paraxial stromal thinning, weakening, results in irregularity in the cornea, and thereby it results in a visual loss. So there are two things in this. One is it is progressive disorder, And second, it causes irregularity in the cornea, resulting in visual disturbance. And that is why the aim of management should be to hit these 2 points. One is the arresting of progression of the disease, and the second is to take care of the irregularity of the cornea and provide good visual rehabilitation. Now, in order to manage these cases, it is very essential to diagnose and detect these cases as early as possible in the form first. That means in the earliest stage wherein even you are not able to diagnose it clinically. If you have a high degree of suspicion, you can detect it by doing topography. So early detection is very essential to provide good management in any case. Now, the question is how we can detect it early. Now, any disease is diagnosed early if we have the highest degree of suspicion in our mind that this is a possibility. And the highest degree of suspicion can be there only if the patient tells us about relevant symptoms. So suspicion comes only when you get to know about the symptoms, certain relevant symptoms of the patient, and then you think about it, do a topography, and then you get to know. So what symptoms will a patient of keratoconus tell you, which will give you an idea that this patient might be having keratoconus? One is that the patient will come with a frequent change of glasses. Somebody who is 17 years, 18 years of age and complaining of frequent change of glasses, there can be two major things. One is the routine refractive error, myopia, wherein you can have frequent change of glasses. And the other one is keratoconus. Somebody who is a 55 years, 56 years of age telling that there is frequent change of glasses, that can be because of a cataract, that can be because of open angle glaucoma. But somebody who is 17, 18 years of age, there are two things that you have to think. One is myopia, and the second one is keratoconus. And the second point, if the patient says that he has suboptimal visual acuity in spite of the best correction by glasses, that will immediately give you an idea that the glasses are not managing the refractive error. This means that there is some irregularity and that has to be investigated. So you have to investigate this patient. And what are the investigations? The first and foremost thing which we always do in our OPD is retinoscopy. Retinoscopy has been very underemphasized in management of keratoconus. But retinoscopy, to my mind, is something which gives you a huge idea of keratoconus, because patient comes to you with change of glasses complaints. He's complaining of change of glasses. So you will give glasses, you will do a retinoscopy. And if there is a seasoning reflex, if there is an oil droplet reflex, immediately the person has to think in the lines of keratoconus. And that is something which is a very cost effective and minimally invasive tool that gives you an idea of keratoconus. Then, of course, you do topography of the patient, you do tomography. Now, by topography means that it is assessing the anterior surface of the cornea, and by tomography, you get a section of the cornea, so you get to know about anterior and posterior surface both. Now, placer-based topography is something which is a good topographer. Topography means that, when you think about topography of the earth, there are valleys, there are depressions, there are mountains. So similarly, you do topography of any structure that gives you an idea of the surface. And placer-based topography is a procedure wherein you get to know about the anterior corneal surface. And there are certain signs which gives you an idea that it may be keratoconus. Like when you do a keratometry, you get to see the malalignment of Meyers and loss of Meyer parallelism. And when you do a video keratography, placer-based topography, then if the patient has a central corneal power of more than 47 diopters, if inferior superior asymmetry is more than 1.4, oblique astigmatism, more than 1.5 diopter, with asymmetric bow tie pattern, with skewed radial axis more than 21 degrees. Why I said that? Because oblique astigmatism is something which is most commonly seen in any topography of a normal individual also if somebody has an astigmatism. But if there is asymmetric bow tie pattern, asymmetry means that you can see this part of the bow tie is larger and this is smaller. There's so much of asymmetry. And then when you draw an axis, when you draw the axis along along these two lobes, this is the axis between the two lobes. And if this axis is skewed a little bit, less than 21 degrees, it is not very significant. But if it is skewed for more than 21 degrees, as in this case, it's 34 degrees, this means that it can be a case of keratoconus. Then, of course, after some time, people started thinking and they got to know that by doing just anterior curvature, anterior surface topography, they were not getting the correct answer to solve the problem of keratoconus. Then came this slit scanning topography, which was OBSCAN, which is very uncommonly used these days because it is almost gone out of market. But this was the first tomographer which was based on slit scanning. So it used to make a section of cornea and it used to give the idea of anterior posterior curvature both. So there was a quad map which was seen in OBSCAN, which gives the anterior elevation, posterior surface elevation, the curvature map, the pachymetric map, and the vital statistics. I won't go into detail of this as it is out of vogue now. But coming to the tomographer, which is used by majority, is based on Scheimpflug imaging, Scheimpflug camera, and that gives that is seen in Pentacam. And in Pentacam also you get to see one curvature map and one pachymetric map. This is anterior elevation map, and this is posterior elevation map. Now, elevation means the position of a point of the cornea in relation to a reference surface. Reference surface is made by taking readings of normal cornea, thousands of normal cornea, and then you create a reference surface. And now, if the patient's cornea has certain points which are more elevated than the reference surface, then the value is in plus, and if it is depressed, then the value is in minus. Now, if you have to detect an ectatic corneal disorder, the value will always be in plus because it will be steeper, it will be higher than the reference surface. And in the Pentacam, the normal value of anterior elevation is 12, while the posterior elevation value is 17 microns. And anything more than 5 microns than the normal, that is more than 17 in anterior elevation and more than 20 or 22 in the posterior elevation, that is suggestive of keratoconus. If the curvature, as I showed, that if there's an asymmetric bow tie pattern with the skewing of radial axis, that can be seen in case of keratoconus, that will be shown in Pentacam as well. Now, as far as pachymetry is concerned, again, we know that in keratoconus, there is thinning disorder. So there are certain parameters based on which we diagnose based on Pentacam that if there is superior inferior ratio at 5 mm circle of more than the difference is more than 30 microns, then it is suspicious, superior and inferior values. So keratoconus is a disease of asymmetry. If there is asymmetry between the two eyes of 30 microns, if there is asymmetry between superior and inferior part at 5 mm of 30 microns, so if there's any asymmetry which is significant, that means it may be a case of keratoconus. And based on that, the Bell-in-M ratio enhanced ectasia display gives you certain parameters like pachymetric progression index, the D values, the ART max, and all these things. I won't go into too much of detail because it's total topography, which will take up time. But the basic idea is this, that Bell-in-M ratio enhanced ectasia display gives you an idea of subtle elevation of the cornea and subtle cases of keratoconus. And all these progression index and the D values, if these are in red, that means it is keratoconus. If it's in yellow, then it is suspicious. Now, there are some definite values like ART max if it's less than 389, if the progression index is more than 1.2, if the D value, average D value is more than 2.6, then all these are suggestive of keratoconus. And then, of course, came this biomechanical strength by use of the Corvus technology, which gives you an idea of Corvus biomechanical index and topographic biomechanic index. And that basically gives you the strength of the cornea. So this is also coming up quite fast to help us to know the cases of keratoconus. Now, if you have certain doubt, like if the tomographer is giving you some suspicious value, but there's no frank keratoconus, there's no definitive sign, you're not very sure about it, then if you have to rule out keratoconus, then you have to take family history, and then you do a epithelial thickness mapping on anterior segment OCT. At 6 millimeter, it gives you a 6 millimeter diameter epithelial thickness marker. And in cases of keratoconus, normally the thickness is about between 50 to 60 microns. Now, in case of keratoconus, the first thinning is seen in epithelium. And if you have an inferotemporal or inferonasal thinning, as you can see here, it's a 48 microns, while superiorly it is 67 and 70 microns. So this means that this is a case wherein even if you don't have a definite values in pentacam, definite ectasia in pentacam, this is suspicious, and such cases should be excluded from refractive procedure. Another case wherein, the inferior thinning of the epithelium, that is suggestive that it may be a case of keratoconus, and it may develop keratoconus on tomographer as well as clinically at a subsequent date, maybe after 6 months, maybe after a year or so. So if you have diagnosed by all these means, then you have to do management. And as I said, that keratoconus is a disease wherein there is progression and there is irregularity in the cornea. So you have to arrest the progression, and then you have to manage the irregularity and provide visual rehabilitation. So for arresting progression, you have to actually document that there is definite progression. And these are some of the findings which gives you that definite evidence that the keratometry and the keratoconus is progressing. And if it's progressing, then corneal cross-linking is the way to strengthen the cornea. The basic idea is that you want to increase the covalent bond between the collagen fibrils so that the cornea becomes stronger. That is the basic idea. And how it is done? The conventional technique is to debride the central 7 millimeter of epithelium. So you mark it with a trephine, then you debride it with the help of, you can use alcohol also to weaken the hemidesmosomes, and then you remove the epithelium. Once you have removed the epithelium, you keep putting riboflavin every 2 minutes for 30 minutes. And then once you have done that, then you focus UV rays, 3 milliwatt per centimeter square for 30 minutes, and keep putting riboflavin. And this is the conventional method of cross-linking. And the results are there to see. Most of the studies and most of the cornea persons are now totally convinced that corneal cross-linking works. It brings stability in the cone, it provides strength to the cornea, and a way to detect whether it has worked or not is to see this demarcation line. You can see this demarcation line. This is the line which can be seen after cross-linking. And this gives you an idea that keratoconus, the cross-linking works mainly in the anterior 2/3 of cornea. And there's a demarcation line there. So till date, the fact is this, that corneal cross-linking is an effective tool to manage cases of keratoconus, to stabilize the cone. But there are certain issues which are there. One is, of course, if you debride the epithelium, the nerves are exposed and the patient has some pain. Second is, it's a long duration. 1 hour of cooperation by the patient is something which sometimes affects. And then, of course, if the cornea is too thin, if it's less than 400 microns, then if you focus the UV rays on the corneal surface, then it can hit the corneal endothelium and can damage that. So these are the 3 issues which keep coming up. And to address these issues, various advancements have been done. So to address the pain, people stopped doing epithelial debridement and did transepithelial CXL. However, most of the studies, they have shown that transepithelial is not as effective as conventional cross-linking. So till date, the punchline is this, that you should debride the epithelium in order to get the best effect. So it's efficacy versus comfort. And when you are talking about efficacy versus comfort, for us, for say 3-4 days, we would definitely like to compromise the comfort for 3-4 days, but we would not like to compromise the efficacy of the procedure. So epithelium debridement has to be done. Second was that it was a long procedure, long duration, 1 hour duration. So people thought that let's increase the power and reduce the time. And this is the Bunsen-Roscoe law, wherein 3 milliwatt per centimeter square into 30 is 90, right? So accordingly, people made various permutation combination, 9 milliwatt per centimeter square into 10, 18 milliwatt per centimeter square into 5, 5 milliwatt per centimeter square into 3 minutes, and 45 milliwatt per centimeter square for 2 minutes. And they again got the same value. And they could see that 5.4 millijoule per centimeter square was delivered. So this mathematics was fine, but was the efficacy also the same? Initially, there was good response. People showed that yes, cross-linking, accelerated cross-linking is as good. 30 milliwatt per centimeter square for 3 minutes was quite effective. But then slowly, people saw that euphoria of this 30 milliwatt per centimeter square for 3 minutes went off. Then there was a study comparing all these, and they found out that the most comparable result to 3 milliwatt per centimeter square for 30 minutes was 9 milliwatt per centimeter square for 10 minutes. And there was no statistical difference between these two. And that is why these days, majority of people are doing accelerated cross-linking with 9 milliwatt per centimeter square for 10 minutes. And this gives a very good result. Now, the third issue was thin cornea. If you have a thin cornea, what will you do? You will hit the endothelium. So people started increasing the thickness of the cornea by using hypoosmolar riboflavin. But then these are paradoxical. You want to make compactness of cornea, increase the compactness, but first you are increasing the thickness by separating the collagen lamellae. So the results are not as good. So then people thought that in order to protect the endothelium, let's put bandage contact lens over it. Let's put smile lenticule over it, so that the distance from the endothelium to the UV rays becomes more than 400 microns. Well, the result, the distance definitely increased, but the result may not be the same as conventional one, as in conditions wherein you have 400 microns, because as we know that cross-linking works in anterior two-third of cornea, and anterior two-third partly was contributed by that bandage contact lens or the smile lenticule, which was thrown away. So the strength may not be as good as in conventional. So people started thinking of doing something more. Maybe we can introduce some intrastomal lenticule and then do cross-linking. This is what we have done our study at RP Center. I've given 2 theses in this direction. In one, 7 millimeter lenticule was used. Then we found out that the results were not as good. Then we have increased the lenticule size to 8.5 millimeter. What we do in this is that femtosecond laser is used to create a pocket. Now, once this pocket is created, as you can see here, the side cut is done, and then the dissection is done. So you create a pocket. Once you have created a pocket, you introduce riboflavin into the pocket, wait for a couple of minutes, and then you take a donor tissue to, I normally use 200 microns, although there's no as such algorithm or there's no nomogram. But donor lenticule, it thins out with time. So any cornea which is between 330, 340 to 300, 400 microns, I use this 200 micron tissue, which reduces its thickness with time and reduces down to less than 120. And particularly what in these 2 studies, what I did was I ablated the central part of the cornea, so the central part of the lenticule, so that we could create a hyperopic lenticule. And then cross-linking was done. So we have done this in a reasonable number of cases, and we are evaluating. It does work to a great extent. Like it provides tectonic support, and then it also allows you, it prevents transplant, it delays transplant for a very long period. And with time, this thickness reduces. It is edema on day 1, but with time it reduces. And then it provides a good, reasonable central flattening as well. So central flattening with tectonic support with delaying keratoplasty is something what we aim for in cases of keratoconus. And with the use of contact lens in such cases, we have delayed keratoplasty in many such cases. So that is something which is coming up fast, and I have also planned a long-term study in this, which is a project under ICMR, and we will definitely get back to you with more data on this. Then came customized cross-linking, wherein people, Theo Sala group, they thought that cornea which is weakest, they should be given more energy, and the cornea which is less weak should be given lesser energy. And that is what is customization. And there are some good results that have been shown, and with time, we'll be able to know. Another thing is that people saw that when we started using UV light, the oxygen in the corneal stroma, it reduced significantly, went on to become zero. So if we can provide supplemental oxygen from outside around the cornea, perhaps the oxygen saturation will be more. And basically cross-linking works because of the presence of singlet oxygen, which provides covalent bond. So that is something which is definitely there. We have done a study also, and we are analyzing the data, and we will get to know with time whether it really works or not. Then once you have arrested the progression, we have to provide visual rehabilitation. In a very early case of keratoconus, spectacles may work or soft contact lens may work, but in majority of cases, we require an RGP contact lens. The bicurve design of Soper lens can be used, but the rose scale lens, which is multi-curve design, it provides a very good centration and coverage. So the end point of fitting is a good centration, movement, and coverage, and a fluorescein pattern of a 3-point touch, central touch and mid-peripheral touch. So 1, 2, and 3. This is what we get to see. So this is a case of a keratoconus wherein a rose scale lens has been fitted. And with each blink, you can see the fluorescein pattern is very nicely seen there. 3-point touch, 1, 2, and 3. And it is very well centered, and the coverage is there. Some patients, they are intolerant to RGP contact lens. So for their tolerance, you can put RGP contact lens over soft contact lens. So you can put a soft contact lens and then fit RGP contact lens over it. So this is called a piggyback contact lens. And this also works in many of the cases. Now, hybrid contact lens is something, again, is a very good tool wherein it is a sort of you can say a piggyback, in the sense that the central part is rigid and the peripheral part for comfort is soft. So this is a hybrid contact lens, which is also quite effective. Only thing is it does have a cost, and it is a little costly. And if the cone is too large, in that case, mini scleral contact lenses are now a modality which work very well in cases of advanced keratoconus, in cases of keratoconus which is recurring in a graft, post-DALC, etc. In all these cases, mini scleral contact lens works quite well. So this is, again, very much there in the armamentarium. It works well. Now, intrastromal corneal ring segment is something which is, again, a very useful tool to flatten the cornea. Basically, it shortens the arc length, and then it flattens the central part of the cornea. So you can create the pocket for the intrastromal ring segment by use of femtosecond laser or even by mechanical separator. So this is how it is done. Femtosecond laser has been fired, and this is a radial incision. And then you open up the radial incision, and then open up the initial part of the track. And then once you have done that, then you place this intracorneal ring segment in position. So one ring segment is there. And then you put the second ring segment also. Two ring segment are there. Then you put a suture here. And once you within the area of the corneal ring segment, and then debride the epithelium, and then do cross-linking. This is, again, a useful tool. This is a post-op picture. That is, happens that it doesn't correct the refractive refractive error completely. So you can either provide the refractive or you can use a toric ICL. What happens that, in cases of keratoconus, you can have very high not at all, such as used as them by put a single second track on a ring set, and then for correcting the refractive you can put a toric ICL. So mark it and then you place the ICL. See. Can you hear me? Can you hear me?
Yes, sir.
Yeah, we can hear you, Rajesh.
Okay. In between there was the internet issue, so I got disconnected. Okay, so once we have put the toric ICL, that corrects for the refractive error. But topo-guided custom ablation is also something which can be done to smoothen the corneal surface, smoothen the topography, and then you can correct by providing toric ICL. You can put contact lens as well. Sometimes it helps in improving the. Basically, is used to correct little bit of irregularity, smoothen the cornea, and not correct the whole of refractive error. Now, the last resort for management is keratoplasty. When contact lens is not able to correct, when the patient is not tolerating, there is corneal scarring, etc., then you can do a keratoplasty. Now, earlier, for any keratoconus, we used to do a full thickness graft. So, because we were not knowing that the lamellar graft can be more useful in keratoconus, so we used to do a full thickness graft. But now, full thickness keratoplasty is only done in conditions wherein you have a central scar. If you have a central scar, then and the central scar is involving the desmase, then in that case, even if you do an anterior lamellar keratoplasty, you will not remove the scar and the patient will not have a good visual outcome. So in such cases, you can do a full thickness graft and you remove the scar tissue and you place a donor lenticule and suture it, put multiple sutures. But if the scar is not there and it is not deep, if it's superficial, and if the scar, or if it's not there, then deep anterior lamellar keratoplasty is the technique which is the preferred modality for managing keratoconus if it is not being managed by any other means like contact lens, etc. So a big bubble, in big bubble dark, what we do is we create a bubble above the desmase, and then we reach the desmase and then inject viscoelastic so that we push the desmase posteriorly. And once we have done that, we cut the stromal tissue and then leave the desmase and take a donor corneal tissue, remove its desmase membrane and endothelium, and then put it. So the basic idea is this, that in case of keratoconus, the endothelial function is very good. So why to compromise on the endothelial function? Why to provide donor endothelium when the host endothelium is already working very well? And what happens that if you have a deep scar, then mostly you do a full thickness graft. But if the deep scar is a little paracentral, then in that case, you can still do a layer by layer dissection and do an anterior lamellar keratoplasty. You can do a maximum depth anterior lamellar keratoplasty, because when the cornea flattens, then the scar which is paracentral goes more peripherally. So that doesn't come in the center, and that provides good visual outcome. And the risk of rejection and the outcome of an extraocular procedure definitely is better than a full thickness procedure. Now, intraoperative OCT helps you to know whether there's any irregularity while you are dissecting. It gives you an idea at what level you are dissecting. It gives you an idea whether in one part of the cornea there is more tissue left. So in that case, you can dissect more and make it a regular bed for placement of the donor lenticule. If there is a ridge here, you can detect it on ASOCT or on intraoperative OCT, and then you can remove that. So you can make a regular surface for the donor tissue to be placed so that the interface irregularity is not there and the patient has a good visual outcome. A word about acute eye drops, acute eye drops in keratoconus. Acute eye drops is a condition wherein the patient suddenly complains of blurring of vision with whiteness in the cornea. This patient is a known case of keratoconus and suddenly develops blurring of vision. And when the patient comes to you, you see this kind of a picture. In such a case, earlier we used to provide hypertonic saline, topical steroid, encycloplegic, etc. But now, along with these supportive therapy, we inject intracameral gas. We inject intracameral gas because it seals the break in the Descemet's membrane. This eye drops occurs because of the break in the Descemet's membrane. So we want to seal that. And once we seal that, we can provide the resolution of eye drops by means of other supportive therapy. And once, as you can see here, the eye drops has resolved and the patient has shown scarring, then after that, a keratoplasty will provide a good visual outcome. Some of these cases, they do well with a mini-scleral contact lens also. We have a series of patients wherein we have fitted mini-scleral contact lens in cases of healed eye drops with Descemet scar, and they come out with good visual outcome. So that is also an option. So keratoplasty is kept as the last resort for managing keratoconus. So in conclusion, I would like to say that keratoconus is still can be considered a mysterious disease of cornea because we have not been able to actually treat it. Whatever treatment we are providing, it is just to manage the irregularity, mask the irregularity, or remove the irregularity, but there is still the chance of recurrence of keratoconus even in a graft. So it is still something, the best treatment will be gene therapy in such cases, which can reverse the keratoconus. Anything which can reverse a disease is the actual therapeutic option. So till date, something like that has not come up. A lot of work is being done. The problem with gene therapy is that there are so many genes involved with keratoconus that, working on one gene takes a lot of effort, and plus a lot of permutation combination has to be done, which requires really, I guess a more development of science is needed in order to provide a proper gene therapy in case of keratoconus. So gene therapy in anything like, in cases of retinitis pigmentosa or keratoconus or whatever, has not come up to mark, and we have not been able to do so. Till that time, we have to do all these palliative measures by masking the irregularity, by providing contact lens, by arresting progression, by use of cross-linking. And if nothing is working, we have to go ahead and do a keratoplasty. Anterior laminar keratoplasty is preferred, but if there is a central deep scar, in that case, a full thickness graft has to be done. So this is something which I just tried, in a concise manner to present to you regarding management of keratoconus. Thank you very much for your patient listening, and I'll be happy if there are some comments which will help us become more wiser. Any comment or any question or anything, any suggestion?
Thank you, sir,
Yes.
for such a nice and wonderful talk. was very informative. And we learned a lot of new surgical intervention and new modifications through this talk. It was really very informative, sir. I would just like to add a point that like whenever a patient come to us, like we should explain him that despite of all the surgical intervention, he will be using the need of RGP lenses is always there, pre and post
Yeah.
any intervention.
Yeah. Studies have shown that nearly 70% of individuals, even after keratoplasty, they do require contact lens for good visual rehabilitation. So that is something which definitely is there. And one thing I would like to say that in cases of primary keratoconus, in early keratoconus and in conditions wherein the disease is not very advanced, we can manage with a corneal contact lens. But once you have done a graft, then many times either irregular cornea design of Rose works, or we have to resort to miniscale contact.
He's talking about publishing multiple.
Deepak is in some other webinar, I guess.
Sir, it's a Dr. Rajesh, sir.
Yes, sir.
Yeah. Sir, for those who are unfortunate to develop keratoconus, unfortunate because there is no therapy,
Yeah.
as told by you that there is something wrong on the genetic level.
Yeah.
So for those who are unfortunately got this keratoconus,
Yeah.
what you have discussed a lot. So I don't find that if the patient goes to a good corneal surgeon like you, he is not going to have the options. You are definitely the list of options which you have enumerated. They are at least one will fit to the patient, and patient will be able to see, and which is the aim of the therapy.
True, sir. True.
So I think a good corneal surgeon who is having a knowledge of everything, whatever you have told, that cross-linking, contact lenses, spectacle correction, the lamellar keratoplasty, how to reduce the high drops, a lot of options you have told. So I think very little is left, not much. And patients are definitely going to, the point is that what I feel in my practice, that still people are not, doctors are not trying for all these options. Most of the doctors are not having, using these modalities. Dr. Rajesh, what is your opinion that how many of the corneal surgeons in India?
एक दवा उसमें भी है.
Sir,
How many corneal surgeons in India are giving and trying all these options in their patient?
well, I think these should be tried in all the patients. And when a patient comes to me telling that I'm having keratoconus and will I have to keep wearing contact lens for life, or will I have to keep coming to a doctor for life? I just tell them that, see, nobody on earth is not having any disease, is not having any problem. And we have to be visiting to doctors quite often. But if you are vigilant about your symptoms, if you are vigilant about any change that is happening in your eyes, and if you report to a doctor, then things can remain in control. And we have seen patients, we have a follow-up of patients whom we started, giving contact lens, long 25 years back, and patient has come for now cataract surgery with a toric implant because his cornea is absolutely stable, everything is fine. So there are patients who do very well.
Yes,
and
yes.
Only thing is they just have to be vigilant about their eyes. They have to come to the cornea surgeon, a cornea person who provides optimal visual rehabilitation. So the idea is that, we are also wearing glasses for visual rehabilitation. So
Yes.
the idea is to provide visual rehabilitation. And the idea is to get visual rehabilitation. And there are so many means. So if we can do that, then till that date, till the time we are doing that, we may not have to worry too much about the gene therapy or whatever.
Yes.
We all have to be very, vigilant about any symptom that the patient says, any new thing that is arising. And keratoconus is a disease of asymmetry. Asymmetry in the sense, asymmetry between two eyes, asymmetry within one eye, asymmetry between patients. Some patient can behave, very badly in the second and third decade only. Some patients can, keep on doing well, and with contact lens they maintain throughout their life. So we have to, one is a very good counseling to the patient also, that is very much needed. And of course, all these measures are required depending upon what the patient needs.
So what about refractive surgery after this cross-linking? Option of refractive surgery after cross-linking?
No, after cross-linking, see, the idea is that, keratoconus cornea is weak. And if we do any refractive surgery to correct the refractive error, which is already high in cases of keratoconus, then the cornea will become further weak. Whatever people have done, the PRK is to just modify the topography a little bit so that the patient has good tolerance of contact lens, and then, or the patient can be provided ICL, etc. So people have done CXL plus, wherein they have done PRK and then they have done CXL. So they have just tried to smoothen the surface, then stiffen the cornea by cross-linking. The idea is not to correct the refractive. The idea is just to modify the astigmatism a little bit, modify the irregularity, reduce the irregularity a little bit, so that the patient is not intolerant to contact lens, or the patient behaves well with the toric ICL in subsequent period.
Sir, one more query from my side.
Sir.
Yeah, I have just recently operated 2 cases of cataract with 348 millimeter cornea and keratometry more than 50. There were central scarring, point scarring in the central of the cornea. 2-3 scarrings were present. What I feel that they are the resolved cases of keratoconus. They are self-resolved cases of keratoconus. They developed keratoconus, slowly and slowly they progressed. But after some time, cornea by itself, with the passage of age, becomes stronger, and they have not landed to the full ectasia or a high drops level. Because in high astigmatism, K1, K2, K1 is more than, at least one meridian is more than 50, and cornea is very thin. These 2 cases I have encountered, and I have implanted this toric contact lenses for this cornea. Definitely the K1, K2 was difficult to get. But what is your opinion regarding this type of cases?
What was the age of the patient?
It is 60.
Okay. So a case, a 60-year-old individual with little bit of scarring was superficial or deep?
348 millimeter thick cornea.
And scarring was superficial or deep?
Superficial.
Okay. So in such a case, mostly acute eye drops happens in a little earlier age, wherein and also in patients who have a habit of rubbing the eye. So these cases have more chance of having acute eye drops. Having said that, it is not completely, you cannot completely rule out in any condition, but at the age of 60, mostly these cases, they are stable only. So in such cases, if the patient develops a cataract and things are fine, then you can go ahead and do a cataract surgery and place an IOL. The only thing is, downside is this, that the corneal thickness is a little too less. It is
very less.
50. Now, if it's 350, I will be a bit hesitant in putting a toric IOL. Rather, I will put a spherical IOL and then manage the corneal irregularity by a contact lens, RGP contact lens. Because he may require keratoplasty later, because the thickness is on the thinner side. Somebody who is, say, 420, 430 microns, 440 microns, and having and is 60 years old with cataract, with astigmatism, one may go ahead and put a toric lens. But in a younger individual with cataract, or in a case wherein the corneal thinning is a little advanced, wherein there is a risk of a subsequent keratoplasty, if I'm doing a cataract surgery, I will put a spherical lens. And whatever corneal irregularity is there, I will put a RGP contact lens. Because if I put a toric lens, I cannot, the RGP contact lens will not work in those cases because it will mask the corneal irregularity. And toric lens is also is being put for correcting the astigmatism. So these two don't go together hand in hand. So we have to put a spherical lens in the eye. And then whatever irregularity is there, as the patient is tolerating RGP contact lens for so many years, he will tolerate contact lens after the surgery also.
Okay. So do you think that there is any advancement of astigmatism at the age of 60 or after the age of 60?
No, it is unlikely. Having said that, it is better to play safe in a cornea which is about 350, 340, which is quite thin. So in cases, it's better to play safe. And if somebody is tolerating RGP contact lens for 60 years of age, he will definitely tolerate it after that also. So he can continue doing that. As far as cataract is concerned, that can be removed. And this RGP contact lens will not be very high powered also, will be less powered because part of the spherical error will be managed by the IOL also. So the stability of the lens will be quite good in such cases. So I don't see any reason. If it was,
irony of the matter is that lady is not aware that she's having any keratoconus any time in the life. She probably has not, probably she has visited so many doctors and the glasses were not properly fitting to her. And she was not aware that they are having this keratoconus. But the age passes and she went to 60. So none of the family member was aware that they are having any keratoconus. So once they came forward with the development of cataract, because it was further deteriorating in a year or so. So that was a very bad thing. So they came and now they are saying कि सब cataract operate कर दीजिए साहब, कम एकदम बहुत कम दिख रहा, पहले भी कम दिखता था, लेकिन अब और कम दिखने लगा हमको. So this is the situation.
In such a case, one may think of putting a toric IOL also, because since the lady has never used an RGP contact, at the age of 60, she will not use for any irregularity. So in case, and you don't expect, if it's not progressing, and at that age it will not progress. So at the age of 60, one may consider putting a toric IOL also in such case, which has never used an RGP contact lens in life.
They were not aware at all.
Yes. Yeah. So whatever best correction we can provide to her, that can be done. That should be done.
Thank you, sir. Thank you.
My only, sir, whenever we are suspecting that the patient can undergo a corneal transplant procedure, we should never put a toric lens.
Exactly. Very right, sir.
Thank you, sir. Thank you. Deepak Kumar, sir. I would like to invite you to give vote of thanks to Rajesh, sir, and all the viewers.
Such a nice discussion. You are closing so early. let anyone, Rajesh, Dr. Rajesh Sinha, Professor Rajesh Sinha is here. He is on the screen. And
that's why, sir,
nobody wants to become more wiser. He has enumerated so many options for keratoconus. How many options we are trying in our practice? What we are doing? We are doing only cross-linking, and that too only traditional cross-linking. Nobody is trying even accelerated cross-linking.
Yes, sir.
Out of this audience, jitne log yahan present hain, how many of them are using accelerated cross-linking, including the corneal surgeon, Diksha Sareen, and everybody? I would like to have a comment from Dr. Diksha.
There are so many corneal surgeons in Varanasi now, and most of them are not present today. I don't know why.
Mostly the earlier protocol, not the accelerated cross-linking protocol we are using. True, sir. True. It's true that we're not using the current newer modality.
This is what I'm saying. Dr. Professor Rajesh Sinha is here on the screen for the Varanasi audience, and vote of things is coming so soon. Let it be decided by Professor Rajesh Sinha when he wants to go out.
Only problem is the quality of talk. The sir has given such a talk that
It's
everyone
such a
is now
wonderful talk. Such a
everyone understand the
beautiful.
things, each and every
Rajesh
point,
has
even the
covered
smaller
each
things.
and every aspect of keratoconus.
He has given
He
at least 15 options to treat keratoconus. And how many options we are trying? How many options all of us are trying for keratoconus? How many of us are giving rose?
Trying is
That's the
different.
basic idea.
Even
We
most
can-
of the options is only in the theoretical literature, sir.
Yes, it is in
We
the
have
books only. But here what he has told, everything can be practiced. Index can be very well done. Why the index cannot be done? Why the lamellar keratoplasty cannot be done? I'm a partial cornea surgeon, not a full-time cornea surgeon. Learned with Dr. Rajesh and Dr. Namrata only. But I still try to understand and comment on this and at least try to follow whatever I can do.
No, that's the basic idea that
Yes, sir.
we keep discussing with each other so that all of us become wiser by, having, getting some knowledge from each other's experience, and we can, all of us can learn from each other. So that is something.
It's a very good refreshment.
Infused in years inspiration into all the ophthalmologists of Varanasi, and to take keratoconus quite seriously now, because whenever a case of keratoconus used to either do something superficial or refer to some higher center.
Just giving some lubricant and all these things, refraction and
so today you have opened our mind, opened our eyes, and we will definitely have quite wiser today with your talk. And I'm sure that with this talk, many will start doing something different. Obviously, take some tips from you. And of course, I'm sure whenever something is required, you are there to help us. You
Absolutely.
are there to give your helping hand, either directly or indirectly, either by coming to Varanasi, also you can do that.
Yes, sir. Sure, sir. Sure. Thank you, sir. Thank you.
Sir, it's a very big service to our society. It's a very big service by this talk, and at least I have learned a lot of things about keratoconus. One of the cornea surgeon is coming to me, but I can question him more, I think, with after going through this session.
The purpose of our today's CME has surely been fulfilled.
Thank
Yes.
you. Thank you very much. Thank you very much.
Now, the question to Diksha, is it recorded?
Yeah. Sir, Dr. Deepak is a better person to answer.
Sir,
Yes, sir.
this time it was not recorded, but we will have, sir, physical meeting with sir.
No
within
issue,
2-3
sir.
months.
Whenever VOS
For this
will ask
talk.
me, I'm always there. We are like a family.
Yes,
we
sir.
will love to have you here, sir.
Definitely. That's a very big statement from Professor Rajesh.
Sir.
So Varanasi Ophthalmic Society is indebted to you,
Sir.
and your wonderful talk. We are all quite glad this evening that from the beginning, at the beginning of the session, what we were and what we are right now are totally different people, almost everybody.
Thank you, sir.
So with these words, I think I should thank you for your gracious presence and your wonderful talk once again and your time. And second, might be a thanks to Diksha, who has started this wonderful webinar, which is, I had proposed last year only to somebody else, but it could not happen. But Diksha has taken this very good step, and I'm sure every month he will be doing something different. It will monthly, in spite of physical meetings, webinar is there to stay. So we have to definitely take this. So we did any different topic, simple topics also. Even the refraction is quite difficult if it is not satisfying the patient. So there are so many topics which you can do in future. And Deepak Mishra, you are a wonderful person. You are jumping from one webinar to another I was with you in another webinar a few minutes back, and we are again together in this webinar also. You are doing a very good job, and I think Professor Rajesh has given you a wonderful thought to put a new chapter in your next book.
Yes, sir. Yes. Thank
Because you are already writing some book, so I'm sure that's coming there.
Yeah, Deepak
And
is
of course,
dynamic persons.
and Dr. R.K. Ojha, you're a gem of a person,
Absolutely.
because unless and until you ask questions, how can that be answered? And I know that you are a tenacious person, very difficult to satisfy, and I'm sure Rajesh would have found it difficult also, but quite efficiently he did say so. So we are all very glad that we have Volunteer Ophthalmic Society has again started a very good webinars, new session in this year. Because last week only there was election and there was new office bearers of Volunteer Ophthalmic Society. Is our president also here in the meeting? Sanjay?
Sanjay sir was there at.
Yeah.
Yes, sir is there.
संजय की फोटो तो नहीं दिख रही है और म्यूट भी है. Anyway, so
Sir
on
is
behalf
busy
of
somewhere,
Sanjay
sir.
also, I thank you everybody, and with this, very good night.
Good night, sir.
Thank you, sir. Good night, sir.
Very good night.
Yeah.
Thank you, Rajesh sir, again for giving
Thank
us
you. Thank you, Deepak.
your
Thank you,
valuable
Ojha sir.
time.
Thank you, Deepak.
Thank you,
sir.
Deepak.
And
Thank
thank
you.
you,
Thank
sir.
you,
Dr.
Diksha.
Sir, in our first webinar, we have more than 100 viewership. Almost 35 to
Wonderful.
36 were connected with us on here, and Facebook and YouTube both. We have our own
Okay.
channel of Facebook and YouTube, and I hope it will increasing slowly and slowly.
Wonderful.
Next time, sir, when
Wonderful,
we call
Deepak.
you, we will definitely cross 200 or 300 viewership, sir.
Yes,
But
So
yes.
definitely.
it is
Yes.
memorable for us that you accepted our invitation, and our first YouTube and Facebook channel has broadcast your
Well done. Well done, Deepak. Well
So
done.
I consider myself very lucky that the first CME of this calendar year was done by me of the VOS, and for that I would like to thank Deepak, Diksha, Ojha sir, Deepak sir, Sanjay sir, everyone.
Yeah.
Thank
And
you, sir.
one last word to every member of All India Ophthalmic Society: please check your mail, because there is one sort of mock election going on. Just check your mail and participate in it. This is for your own society.
Okay, sir.
Okay, sir.
Thank you.
Thank
Good
you,
night.
sir.
Bye,
Thank you,
sir.
sir.
Good night.